It is my pleasure to introduce Ranjani Paradise, who is the Director of Evaluation at the Institute for Community Health, where she oversees ICH's staff training program and leads the development of ICH's evaluation services and substance use disorder portfolio. In her time at ICH, Ranjani has been the project director for mixed methods research, assessment, and evaluation projects across a range of topic areas, including workforce development, community power building, and advocacy for health justice, health equity, and behavioral health. Much of her work over the last year has focused on overdose prevention and substance use disorder treatment programs in Massachusetts, and she has worked with a wide range of community health centers, hospital systems, and community-based agencies. She is currently the project director or senior advisor for several research and evaluation studies of programs seeking to increase racial equity in substance use disorder services and recovery support services across the Commonwealth. She's given this talk to my staff, and it is awesome, and I hope you pay attention because there's a lot to learn from this talk.
Thank you for that introduction. I'm thrilled to be here, and I really think a lot of what I'm going to share today is just so resonant with everything that I have heard over the course of this meeting. So I think there's going to be a lot of synergy. So what I'm going to be doing, I'm going to be sharing some findings from the Boston Overdose Linkage to Treatment Study, which we call BOLTS. And really, this session is about listening to the stories of opioid overdose survivors, and really centering their experiences when we think about what kinds of positive changes we can all make in our own practices and in the settings where we work. All right, so I'm going to start out just quickly with some background so we can get right into the findings. BOLTS is a qualitative research study. The overall goal is to understand racial and ethnic inequities in access to treatment, specifically for overdose survivors in Boston. And the study grew out of some previous work that was done by the Boston Public Health Commission, which had analyzed data from the Public Health Data Warehouse. And the sort of big piece was that they found that Black and Latinx people in Boston were less likely than their white counterparts to have entered substance use disorder treatment in the 30 days following an opioid overdose. So BOLTS was really designed to understand that, explore what was going on that was underlying those trends. I just want to note here, this was a multi-institution collaboration. This whole project was possible because of partnership between ICH, where I work, and co-investigators and team members at the Boston Public Health Commission, Boston Medical Center, and BU School of Public Health. And the funding for this study came from RISE Massachusetts Foundation. So we had three main research questions for BOLTS. The first was around understanding the general barriers and facilitators for accessing substance use disorder treatment after an overdose. The second was looking more specifically at what are the factors that contribute to racial inequities. And the third is really identifying recommendations for what to do about it. I'll just say, even though this study was originally conceptualized in 2019, I think all of these research questions remain highly relevant today, especially in light of the recent overdose mortality data that I'm sure everyone here is familiar with. I'll also just say our inquiry for this study was really centered on Boston geographically, but I think that the themes I will share will really resonate with all of you who work in different parts of the state, as well as places outside of Massachusetts as well. So just a quick overview of the data collection here. We had two participant groups. The first was opioid overdose survivors. We had 59 people that we talked to in that group. The criteria there was that the participant had to be living in Boston, had to have survived an opioid overdose within the past 3 months of when we were engaging them, and had to identify as Black, Latinx, or white, really because of that original quantitative work that we were building off of. We did all of that data collection in 2021 with most of the recruitment happening through the Engagement Center in the Massachusetts area. We also had 28 key informant participants, but I'm not even going to get into that side of the work at all today. I'm just going to focus on the findings from the overdose survivors. So with the overdose survivor group, we had a pretty detailed demographic and drug use survey. and then a qualitative interview guide that had explored a range of topics relevant to those research questions that I have shared earlier. So I'm just going to give a caveat that I always give when I give this presentation, which is that there's a ton of information that came out of this study. I'm not going to have time to do a deep dive into anything. I'm going to hit on a number of different topics that we learned about, but I am always happy to talk more with anyone who wants to dig into any of the themes in more detail. So first, just to orient a little bit to who we talked to, the characteristics of the people that are sharing their experiences here. These are just a few selected data points from the survey to give you a sense of who this population is. So first, we did purposive sampling on racial and ethnic identity, basically because we were seeking to get a roughly equal distribution across Black, Latinx, and white participants. So you could see that reflected in the numbers. We saw that almost 3/4 of our participants identified as male. Most people were between the ages of 30 to 49. And almost 3/4 had lived in Boston for at least 5 years at the time of the interview, so they were not particularly new to the city. And then looking at the social determinants characteristics on the right, I think that the point that I want to highlight here is that the people we are talking to really they had significant social vulnerabilities. They were really at the intersection of multiple identities and experiences that are historically marginalized and underserved. So just a snapshot, 3/4 of the people we talked to were experiencing homelessness at the time of the interview. 85% had a history of incarceration, and almost 90% were out of work or unable to. So now looking at health status and drug use, I'll first just draw attention to the fact that participants were rating their physical health status, just on average, a bit higher than their mental health status. And then with drug use, almost everybody reported having used opioids in the past month, and almost everybody had reported having used stimulants in the past month. So polysubstance use was very common with this population. And then I think another really important point here is that almost everybody had multiple overdoses in the past year with a median of. So before we get into the qualitative themes, which are really kind of the core of this study, I just want to give you a sense of the treatment and recovery history for these participants. So here I'm using a version of a cascade of care model that probably this group is pretty familiar with, typically depicted in a linear format like this. So, our study wasn't designed just to really put numbers on every step of the cascade, but just based on the stories that people told us, what we learned was that almost every participant had done substance use disorder treatment in the past. Some of them had done multiple programs. They had tried different forms of medication. They had been through residential programming. Some of them talked about periods of recovery that they'd had in their lives. But just by virtue of our criteria for this study, we know that everybody had experienced an opioid overdose in the past 3 months. So everyone, even though many of them had done treatment in the past, they had all experienced some kind of recurrence of their substance use disorder or a return to drug use. And less than half had engaged in treatment after their most recent overdose. Actually, before I advance, I just want to say here that the thing that I really want people to take away from this is that these participants had a lot of experience with treatment. But the system, the way that they experienced it, was not successful in supporting their long-term recovery. So I think that point you all may understand, but I do hear sometimes people saying things like, particularly about the population in the MASAM Cascade area, that people don't want treatment, or they're not looking for treatment, or they're not trying. And that is not the case for the group of people we were talking to. So now I'll move into some of the qualitative themes for what came out when people shared with us their experiences. So we heard about a lot of different factors that affected access and equity for participants. So the way we try to make some sense of that is we organize them into levels using a social ecological framework. So I'm going to walk through the themes at each of these different levels and then try to tie it all together at the end. So starting at the individual level, so first, as I had just said when I showed the cascade of care, these participants were very experienced with treatment. They knew a lot about the options. They knew where they could go to access services. And you can see just from the quotes here, people can describe in great detail the resources that are around them and the way the system works from their perspectives. So at least for this group of people, they didn't feel like knowledge or awareness of options was a barrier for them. Another topic that we explored specifically with these interviews was participants' experiences and their opinions and perspectives about medication as a treatment option. So 4 out of 5 participants talked about having used some form of MOUD in the past. Some of them, like I said before, had tried multiple medications. But less than a third were still on MOUD at the time that we did the interview. So I think that just highlights an ongoing need to really think about retention in treatment, and what are the reasons that people might drop off. And one other thing that I'll note here, we only have a point in time snapshot, so I try not to overinterpret the quantitative differences, but I do think it's notable here that we didn't see differences in medication initiation by race and ethnicity. But yeah, the Black participants that we talked to were less likely than the others to still be on MOUD at the time of the interview. So now, really, what did people think about medication? How did they feel about this as a treatment option? The first note is that there was a wide range of perspectives and viewpoints about medication. There's variation within and across racial and ethnic categories. I think that's just important to highlight because we always need to remember that there's not a single opinion that a whole community holds. We need to really be thinking about each individual's perspective and responding to that. And again, with the caveat that we have small numbers here, one trend we noticed was that Black and Latinx participants in general were more likely to have to sort of express negative or critical views of using medication for opioid use disorder. So this is a selection of quotes really to illustrate the range of perspectives that people expressed. So I'll just highlight the one on the bottom left in the green box. So this person says methadone is okay. They say it helps. They talk about it if you kind of take it the way you're supposed to. They say it's okay. But interestingly, this same participant says that they don't like Suboxone because they think Suboxone is substituting drugs for drugs. So I want to highlight that quote in particular. And I think if you read the other ones, you'll see, kind of a spectrum of how people are thinking about this. But I'm highlighting that one quote in particular just to show that people are holding a lot of different ideas about medication. They may not always be the ideas that we here want them to have, but that it may be more complex than we expect. The perceptions people have may not align with what we're thinking the issues are. So now turning to interpersonal factors that are related to the experiences that people have when they are interacting with the people who are delivering care and services. So the first point here, I think this is an obvious one, but worth just saying every single time I give this presentation, which is that the interactions with staff make a huge difference. So they can be a major barrier, or they can be a major facilitator to engagement, depending on how it goes. And that goes for every interaction with every person that someone sees or talks to when they walk into a program or an agency or a hospital or a health center. Now, one of the major themes, as has been touched on already, many times in this meeting, a lot of people talked about times when they felt stigmatized, treated poorly, disrespected. This is very common, especially in hospitals and substance use disorder treatment programs. And when people would talk about this, they would use language that really highlighted that they felt dehumanized. They would say, I was treated like an animal. I was treated like garbage. I wish people would just see that I'm a human being. So really using that kind of language that was showing how dehumanized they felt in these settings. And then people talked about being stigmatized as a person who uses drugs, sometimes as a person who presented as visibly homeless. And then some of the Black and Latinx people also talked about experiencing interpersonal racism in these settings. So really, though, it was about the intersection of drug use, homelessness, and being a person of color that for a lot of participants was leading to just multiple layers of stigma and marginalization when they were entering these environments. So I'm going to read just the quote here on the right. This person says, and this is a person who is, going into a place where he's looking for help. And he says, they all know I'm a junkie. I get treated with disgust. They don't want to get close to me, and they talk about my look. They say I'm dirty and I stink. Now, in contrast, I do want to highlight the positive side, the places where staff made participants feel cared for and respected. This was usually in harm reduction oriented settings. And I will acknowledge there's some bias there in that we were recruiting people in those settings. We're talking to people who chose to be there. But I still find a lot of value in just really looking at how people talk about those interactions compared to other places that they went. And I love this quote here, this story. This is a person, they're talking about the engagement center. And they tell this story of a time that they went into the engagement center and they had lost a shoe with something that happened with a street cleaner. And what they say about the staff, they say they really care. They would stop their own job to make sure you got what you need. And they describe, that they came in without a shoe, and they say, the staff was like, you only got one shoe. The staff is always engaging with us. We don't get a chance not to engage with them. If I'm walking in like this, they'll be like, what happened to your shoe? I can't just pass by quietly with no shoe on. And I think that is just such a great example of what people are looking for. This person, it was all about having someone see them, notice what's going on, proactively engage, that demonstrated that that staff person cared about them. So the last theme here in terms of interpersonal interactions, and I know this has come up repeatedly in this meeting as well, one really big theme was that survivors really talked about how they wanted to work with people who had similar lived experiences and, characteristics to themselves. So the really predominant thing that people emphasized was they wanted to work with people who had experience with addiction, lived experience with addiction. So some people talked about other elements of identity or experience, but really having staff who knew what it was like to be a person who uses drugs or have a substance use disorder, that was the predominant thing that people said that they wanted. So this person quoted here says, you can read a book on it all you want, but you still never walked in those shoes. I'm going to listen to the person that has yours clean because they've been in my shoes. And I think that just really highlighted people are looking for someone who gets them. And this was the feature for this particular population that they really felt was most important. So next, I'm going to move on to some more process and policy kind of program level factors. The first thing I'll start with here is the process of overdose response. So the opportunity to connect people to services at the point of overdose response and how that went for people. So about 2/3 of the people that we talked with, when we asked them about their most recent overdose, they talked about having a touch point with some kind of medical or sort of professional staff person that administered naloxone and reversed their overdose. Most of those people said that somebody talked with them at that point about options for further treatment or medical care. So that's good. That means that most of the time people are offered an opportunity for linkage to care at this particular touch point. But there were still some gaps. There were several participants, all of them were people of color, who said that no one discussed treatment or services or a linkage or further connections with them at that point in time. So I think that just highlights an opportunity to, always be looking at processes, seeing where the gaps are, examining if there might be bias in how things are working, and that there's an opportunity here to make an existing process that seems like it's pretty good, making it just tightened up so some of these gaps could be closed. Now, some people also talked very clearly about wanting more proactive offers of help or more support to make a successful connection to services when they're offered. So this quote here, this is a person who was treated in a hospital and was then given, after stabilizing and being discharged, was given a list of detoxes to call, and that was it. And they describe very specifically exactly what they wish their care provider had said to them with great detail. And what this quote shows me is that this person is not looking for information. They're not looking to know where could they go. They are looking for someone to show that they care by offering this, starting this conversation and offering this to them. And I think here it's important to note that some people are not comfortable asking for services if they aren't offered. There are power dynamics in these settings, racial dynamics sometimes, and people are in a vulnerable state following an overdose. overdose. They're really relying on the treatment provider to initiate this conversation. And it's again, a demonstration of caring when somebody offers, even if the person does not want to engage in treatment at that point. There was another participant who I interviewed who talked about this, who was very clear he did not want to engage in services, but he wasn't offered and was not happy with that. And he really said, shouldn't someone be extending, he called it, I think, an olive branch, shouldn't somebody be extending the branch to me, no matter what? So I think over time, maybe one of those extensions will result in the person, that'll be the day. But people are really looking for that because it shows that the provider cares. So the last thing with regard to that specific kind of point in time, the overdose response process, is that some people described really strong emotional reactions after their overdose, which I think just highlights there's just a need to be able to provide some kind of mental health and emotional support at that point in time, in addition to the medical monitoring, which is of course critical. But people would talk about just how they were feeling and kind of not having any mechanism to be supported with that. So this person talks about after the overdose reversal, how he felt. He said, I felt betrayed. I felt ashamed. I felt stupid. I felt worthless. I felt like an idiot. I felt angry. And then I felt embarrassed as I began coming back to life, being embarrassed. So next, here, I think probably some of you have experienced this. There were people who were seeking a bed at a detox program or another step in the residential continuum and couldn't get one because of lack of availability at the time that they were looking. And then in addition to that, people shared some specific issues or challenges that they had with detox or residential programming, which then became deterrents to them wanting to seek those kinds of services in the future. So some of these included policies that were people felt were too restrictive and limited their freedom, feeling like they just needed more and the programs were too short. Some specific issues with withdrawal management protocols at some programs, and then some people who just didn't want to do things like group-based treatment and felt like they were kind of forced to. And here's a couple quotes on this, and here I'll draw your attention to the quote on the right, because this participant says that the program he went to felt like jail. And as I said in the beginning, almost everybody that we talked to here had been incarcerated in the past. People didn't sort of say this connection directly to us in the interviews, but I think it's pretty reasonable to assume that environments that remind people of jail are triggering or traumatic, or just not what people are looking for at this point in their lives. So there were also some specific issues that people raised for why they found medication to be challenging or felt like it didn't work for them when they had tried. So some people experienced dosing that wasn't effective or tapering that was abrupt, and they just didn't know why it was happening. Sometimes just difficulty scheduling, tracking appointments, some specific challenges regarding methadone, just it's hard to keep up with, or people would some comments that just felt stigmatizing, too public to have to go to the clinic. And then some people did have experiences with their prescriptions being taken away or stopped. Sometimes this was due to diversion, sometimes suspected drug use. And I'm not a clinician, and I don't know a lot about the circumstances here with regard to what would be the best clinical decision for these patients. But I think the real takeaway is that people felt like decisions were being made that they didn't understand. They sometimes felt like policies were inflexible or punitive. And I think they didn't feel like they were invited into a conversation to be a partner in figuring out the best care plan. I think they just kind of felt like things would happen to them and they didn't have any part in that. And I think, we talked a little bit earlier on about the different viewpoints or perspectives people have about medication. And these experiences would add to that and just make people feel like this is not something that works for me. This is not something that I want. Something they would walk away feeling like, I don't want to try this again. And especially if someone is already holding a viewpoint where they don't really believe that this is a good way to go, this can really be damaging to their future engagement with trying medication again. So now moving into systemic and structural issues, I want to start with social determinants of health. I'll say participants had really significant social needs. As I said, it showed at the beginning with some of the demographics. Housing was the major one. About half of the people we talked to were living on the street when we interviewed them. Another quarter were in shelters. So In addition to housing, though, people talked about other social needs, including employment, access to transportation, sometimes just some very basic resources or supplies they needed for their daily lives. And I think just the social determinants of health were just so central to what people needed, what was influencing their quality of life, and what they wanted to have in place in order to be able to move towards whatever their goals were for their life, or be able to focus on treatment or recovery. So some quotes here regarding social determinants. I think the one on the top left really kind of just hits it. This person says, I think the most important thing to recovery is knowing you have a safe place to go every night. And I find the quote on the right powerful too, because this person is saying they wish they could just have a bag of some basic things, like clean underwear. And they say, this is probably far-fetched. And I look at that and it's like, we should be able to do this, provide people some basic dignity. This shouldn't be something that someone feels is a far-fetched thing that they can't have access to. And I think really, these comments highlight how we can't treat substance use disorders in a way that's separated from someone's overall life circumstances, to really see how the social determinants are intertwined with drug use and with a person's ability to engage in their path to recovery. And then the final theme here is around mental health. So I think some of the previous presentations highlighted this, that people had a lot of experiences with trauma. That was aside from the trauma of overdose itself. A lot of people talked about mental health conditions that that weren't being treated or weren't being adequately managed. For some people, they described how social determinants like housing insecurity or the pandemic had made their mental distress worse. They talked about using drugs to cope with untreated mental health conditions. And then there were stories where untreated mental health conditions became a barrier to substance use disorder treatment, or vice versa, which I think probably relates to just people not having enough access to mental health care in general, but also just needing more places where they can go, where both their mental health condition and their substance use disorder can be treated effectively together. So the quote on the bottom here, this is a person who wasn't able to get the mental health medications that he needed. And he talked about how he didn't want to go into a substance use disorder program because he felt like he just couldn't be successful if his mental health wasn't under control. So I want to share one story here that just shows how these barriers occur at multiple levels. These are not occurring one at a time or like in a separated way for people. People are going through experiences where multiple barriers happen all together. So this participant, all the names here are pseudonyms. This is, we're calling him Omar. Omar is a Black man. He's not a native English speaker. So what he talked about was that he had completed a detox program. He was looking for a CSS bed, but he wasn't able to get a bed right away. So what he was told was that he'd have to wait a week. He didn't have a place to go or a place to live. So he ended up going back to the street. In that time, he had an overdose, at which point he was taken to the hospital. At the hospital, he felt like he wasn't treated well. He wasn't treated with respect. And then at the end, as soon as he was stabilized, he was told to leave, and nobody initiated a conversation with him about further treatment. So this is a person who was actively looking for treatment, who wanted help. And his story, I think, just shows how capacity limitations, just a missed opportunity to start that conversation, negative interpersonal interactions, and homelessness all together for this person resulted in him being back in a very high-risk situation. So just to close out, I just want to take the themes and highlight some opportunities for moving forward. So first, just kind of summarizing some of the key points coming back to that cascade of care. And here I generalize the cascade model a little bit. And one point here is that we have to think about every step in this cascade, not just the initial entry into treatment. Recognizing that this is not a linear path for a lot of people, what are the ways to facilitate re-engagement and reinitiation of treatment when that's needed? And I think both participant stories really show us that if someone has a bad experience the first time around, it's going to be harder the second time around, and even harder the third time around to re-engage. Then in thinking about how to improve outcomes at all steps in the cascade, so every green arrow in there, people shared barriers at multiple levels. And I think if we generalize these themes beyond this specific population, we know that the barriers people talked about are related to institutional and structural racism, which means there'll be a heavier burden on people of color. We kind of like think about this in a broader way. which means all of the levels and the associated racist structures have to be taken into account for solutions to be sustainable and successful in the long term. And then the last point I'm going to make is that I am sure the themes I shared with you today were not a surprise. I think it's really powerful. It's really important to hear directly from the people that are going through this, but we already know what the issues are. They're not new. The stories are not surprising. And I think the question really is, what can we do to put this information to action and make some changes? And I will say every panel so far in this meeting, I think, has already highlighted things that can be done that are within reach. So I'll emphasize one more time that the people we interviewed had a wide range of experiences and individual needs and priorities. So there's not going to be a single solution or intervention that will work for everybody. We really have to think about multiple approaches, multiple pathways. So thinking, no wrong door, but also lots and lots and lots of right doors in many different places. And based on what we learned from Volts, I'll just share kind of 3 categories of change to think about. So the first, I think, is the low-hanging fruit, kind of near-term opportunities to make those process improvements, local changes that we can make to improve programs as they exist within their current structures. I think the next category is more cross-sector collaboration so that we can provide people with more comprehensive resources and services, but still kind of like within the systems the way they exist, but connecting better, coordinating better. And then the third is to think about the bigger and broader systems reforms and redesigns that we might want to be advocating for to create a system that really can support sustainable change in the long term. So I have compiled ideas here about opportunities for improvements that come out of the study. I'm not going to go through them right now. I think a lot of what you all have talked about already hit on a lot of these. One thing I'll say that I think is just underlying all of this is that every interaction and every experience that person has is an opportunity to build trust or an opportunity to diminish trust. And trust is just foundational to being able to do any of this, to being able to support a person to be safer, to kind of find their path forward. So that, I think, just thinking about what are those maybe small opportunities to just show compassion, build trust are just critical. And then lastly, I want to share 2 stories with you that are positive stories that I think highlight the huge impact that care providers can make when that foundation of trust is in place. So I'm going to start with a participant we're calling Charles. He is a Black man who was on Suboxone. He wasn't taking it regularly, ended up overdosing. After his overdose, his doctor switched him to Sublocade. So Charles describes that they had already been talking about Sublocade, but the overdose was kind of the turning point to make that change. And he says the doctor really taking this seriously and saying it's time to make that change. He says, it showed she really cared as a physician, you know what I mean? The other really important thing is he had heard good things about Sublocade from friends. So there was a kind of positive peer influence that made him think this could be a good idea for him. And at the time that we interviewed Charles, he was just having a really, really positive experience. He was talking about how well it was working for him, so much better than what he had tried before. He says, I think this would be the best thing for a lot of men of color. He was really just glowingly talking about Sublocade and how awesome it was. And, how his doctor had explained it to him and showed him the way it works and really kind of helped him understand how this could be a good choice. And I think this illustrates how there can be a positive outcome when, one, that social influence is supportive, but also having a provider that this person trusted, who's willing to stick with him through ups and downs and through overdose and make changes and work with him to find something that was going to work better, that I think really left him with a sense of hope. And then the second story, this is Daryl, a Black man who was admitted to the hospital. He had a severe hand infection and he was thinking about leaving. This is just exactly what we talked about in the last session. I think a story of a success with an addiction consult program. He was thinking about leaving, but the doctor convinced him to stay. So what the key points here, he says first his main physician he was working with explained to him, why it was important for him to stay and assured him that someone would be coming in, a specialist would be coming in to talk to him. I do want to highlight here that Daryl says, I lucked out, meaning that the first doctor that he worked with he says he was a pretty nice guy, I lucked out, which shows that maybe that is not the common experience that he is expecting to have. So maybe that's something to be working on, but this worked well for him. This guy treated him with respect, explained things to him. He felt like he was a nice guy. And then there was a follow through, right? The specialist came, also treated him well, gave him methadone, took care of his concerns and what he was feeling, and convinced him to stay and get the treatment that he needed. So I think we might have a few minutes for questions. I just want to take a moment to just do some acknowledgements. First and foremost, I want to thank all the study participants. Their insights and experiences and expertise is really what this is all about. For confidentiality, I cannot thank them all by name. If I could, I would. I'd like to thank the study team, everybody who was involved from all of our partner institutions who, it was really a big team effort to make this happen. And then just our funder acknowledgement, Rise Massachusetts Foundation, who funded this work. Happy to take questions.
Thank you so much. My name is Heidi Ginter. I'm a person who is very much aligned with what you're saying, addiction doctor, family medicine physician. One of the things that I've found, I'm hearing more and more, is that it's really all about loving the person in front of you as a human being who's suffering, who deserves the kindness of a human being who has the power to relieve the suffering, which is really an attitudinal change, right? So if all of us have the right attitude, how can we transmit the benefit and the joy of this kind of work to other people who don't currently have that attitude? I feel like there was a time in my practice, I've been practicing addiction medicine for a little less than 2 decades now. In the beginning, I was very much talking to people about methadone and about buprenorphine and what it could do and how it worked. And now I feel like I need to sit in front of people and teach them how to be nice. So I'm hearing all of us saying the same thing. How do we do that work? Do you have suggestions on how do we transmit the nice virus so that we can have better response? That's my thought. Like, how do we do that? Thank you.
I don't know that I can totally answer that, solve that conundrum. I'll say a couple thoughts, that I've had doing this work. I think one is, what can we learn from harm reduction programs? I think places that are just viewed so differently. What do they do? How do they hire? How do they train? Where do their staff come from? I think there's probably insights there. And then the second thing I'll highlight too is just, there are also systemic and structural issues within healthcare systems that are creating circumstances of deep burnout and trauma that I'm sure a lot of you are experiencing, that do contribute sometimes to what comes out in the interaction. So I think there's part of it that's about the individual, and then there's some of it too that we need to look at what is happening that sort of makes people act a certain way sometimes, maybe when they're just so overloaded, and how could we address that too?
Michael Beer, Boston. Wonderful talk, great work, insightful, enlightening. Thank you. I have a reflection, and it's sort of a softball for the board of MASAM, I guess. You highlight overwhelming structural problems, homelessness, for instance. And, as a doc in a room with a patient, I feel a little disempowered, if not impotent, to change structural and systemic problems that affect patients' recovery and condition their lives so much. So I guess my softball for the board is, does MASAM have a role in these bigger structural issues, and how do we advocate for those changes? Because I think for my life to feel like a coherent whole, I need to know that somebody I'm working with is taking care of the big picture.
Unequivocally, yes. We do a lot of advocacy work, as you know, but not everybody in the room may know. But more needs to be done, to your point, Michael. And you're right, when you're in the room with the patient, it can be you can feel very disempowered to fix the things that affect patients' lives. That's why we're here. And that's why we are elevating this talk, because for me personally, we can quibble as we did all day yesterday about dosing methadone, but what really matters is this.
So, yes, let's clap to that. And really thank you for your work and such a great presentation. Again, Jimena Sanchez Sanfed, Charles River Recovery Center. I do want to echo what my friend and colleague, Dr. Ginter, said, and just really, again, just share a comment that unfortunately I do agree is common to most of us. I've been in the field for also 20 years, which just sort of dates me as well. And my burnout really comes from the having to apologize to my patients for having to send them to the nearest emergency department. And that's unsettling to me. Like, I love my work, I love my patients, and the part that continues to burn me out is precisely that, right? The having to excuse myself for an encounter that they're about to have that I know, unfortunately, is going to be judgmental, stigmatizing, and that they're going to be left feeling, unsettled, and we have to do more damage when they're returned back to us because of how they've been made to feel. So I, count me in MASAM, anything, that I think a lot of us here are ready, willing, and able to do, to leave the judgment and stigma at the door. You have me in. Thank you.
And I think one point there, just to reinforce again, which also, was a core piece of the last presentation, is just pathways for people with lived experience to be part of that workforce, I think is also just, that's what people say makes them feel, like they are welcomed, like they belong there, like someone sees them. So I think there's definitely work to do on what can everybody do to be demonstrating those behaviors, but what are the bigger advocacy agendas that need to be in place to create really sustainable, I think, career pathways for people with lived experience.
Wonderful talk. Thank you. And I want to ask you something that's probably inappropriate. The theme that one of the themes that comes through is homes, homelessness, and how important that is. And you're in the midst of Boston and the troubles. So do you have any insight about what we can do about providing homes for people? And I apologize for going beyond your specific talk.
No, it's a great point. I think there's some interesting work happening with low threshold housing sites in Boston that are specifically like trying to create pathways for people. I guess something I worry about with that is it's a similar issue to kind of what I was highlighting with the care continuum for substance use disorder, is that a short-term intervention or getting someone into that first step is wonderful. And for, people, I think, my organization is involved in evaluations of some of that work. And when you talk to people about their experience, they are thrilled and so grateful to have, a pathway, an easier pathway to a place to live. But they also say, when I move, I need this, and this, or they say, I'm scared to move. I need, this, and this to support me. So I think there's some great work happening that is going to produce positive outcomes. We also have to, I don't know the solution for the longer term piece, but I think we always have to be thinking about longer term supports, and that this isn't something that's going to be easy for people to, suddenly be on a different track without help.
Abdul, Addiction Medicine from BMC. Thank you again for the wonderful talk, and it resonates with the daily work that we do. The one question I had was, as we are an immigrant nation, a diverse society, I'm wondering if the study had any theme of how immigration and refugees status correlates with addiction, stigma, and disparity, and how the way ahead, how can we decrease that?
No, that's a great question. I think this study didn't really have a lot there. I think partially just the sampling. We didn't talk to a lot of, we did talk to a lot of people who had either been born in the US or had been in the US for a long time. Those themes didn't really come up. I'm sure they are absolutely present. We were sort of struck by language barriers not coming up. Also, even for people who, had a primary language of Spanish, and we asked specifically about it. And then sometimes people would say, nope, that's not an issue. There's Spanish speaking staff everywhere. So I think there's probably, more that can be provided. I think immigration, linguistic and cultural access are absolutely really important. They just weren't kind of like big themes that came out of the people we happened to talk to with this study. And I think also thinking beyond the Spanish speaking population is another piece. We didn't talk to people from other areas of the world or who had other language preferences. So there may be additional needs there.
Thank you.